Still morning. Good morning, everyone. It's, as others have acknowledged, it's an absolute pleasure to have been invited, and I'm honored to be able to share some of the lessons that we've learned in Pennsylvania about, specifically about the role of intermediary organizations in the effort to scale up, in this case, family-focused preventive interventions. And so I'm going to talk about intermediaries and the role that I think intermediaries could play in achieving that goal. And I'm also going to focus on the specific benefits I see to having those intermediaries operate at a state level. I want to acknowledge the Pennsylvania Commission on Crime and Delinquency that has funded all of the work that I'm going to talk about for 2 decades, almost entirely out of state funding, not even federal pass-through funding. Before I go on, this is Flat Stanley, and so he has nothing to do with my presentation, but I need as many people as possible to take their cameras out and take a picture of me with Flat Stanley, because he's going to help my friend Cameron learn about the National Academy of Sciences. So if you have a camera, anybody? No, really, seriously, can somebody take a picture? We're not moving on until someone takes a picture. I made Cameron a promise. All right, thank you. All right, so I just want to restate the challenge. How do we reduce the incidence and prevalence of negative cognitive, affective, and behavioral outcomes among youth in the United States? And this is a reframing of the way that it was worded in the language that I received about participating in this, because this was the second part. The focus was really on, how do we scale up effective interventions. And this has been stated earlier. I think Lauren pointed this out, but it bears repeating because in our 20-year history in Pennsylvania, we made this mistake. We spent a great deal of effort in the early years of this initiative that I'm going to talk about, mistakenly thinking that the goal was to disseminate evidence-based programs for the purpose of reducing incidence and prevalence. So to do that, we want to provide effective family-focused interventions at sufficient scale and reach, maintain sufficient quality and fidelity, and I would argue that those 2 things work at cross purposes. The greater scale you go to, the harder it is to maintain quality and fidelity. 2 strategically identified populations, again, so not just pushing programs, evidence-based programs into communities because they're on a list of evidence-based programs, but to address strategically identified needs in specific populations and sustained over generations. So the issue of sustainability has been mentioned a couple times already this morning, but I don't think it gets enough discussion in this conversation about scale, especially when we're talking about scaling preventive interventions. Because I don't know about the rest of the country, but in Pennsylvania, there is no stable infrastructure for prevention. There's no system that's responsible for prevention. Prevention gets done by a patchwork of community organizations and nonprofits and mom and pop organizations and grassroots, church cellar, and it's all funded by this patchwork quilt of yard sales and bake sales and car washes and temporary grants. So sustainability is really a big challenge to making that leap from knowing what works to having a population-level public health impact. So I'll tell you about some of the lessons that we've learned in this 20-year case study in Pennsylvania. And what Pennsylvania has done over the last 20 years is attempt to scale up what originally was the original list of blueprints for violence prevention. And I think Pennsylvania is unusual, if not unique, in that Pennsylvania has attempted to scale up this whole menu of preventive interventions, not just 1 or 2, but this whole, but an entire menu of that goes across developmental periods, that goes from universal to selected to indicated interventions. So this is the menu of interventions currently that Pennsylvania has endorsed and is actively promoting. That doesn't mean that these are the only things going on in Pennsylvania. It just means that there is a dedicated effort to promote the scale-up of these specific interventions. And there was a whole history that I can't get into about the discussions and conversation that led to each of these being on this list. And we're just in the early stages of going through a pretty sophisticated gap analysis at the state level to revisit this list and determine whether there are other things that should be added to this list or whether there are things that should be taken off the list. So in terms of the goal of dissemination, this was our footprint of evidence-based programs in Pennsylvania in 1999. This is our footprint in 2013. So if dissemination of evidence-based programs was the only goal, we have made significant progress, and this is good. I mean, I don't want to underplay how important it is that we've gotten this kind of market penetration, if you will. And those counties that don't have any green or dots in them, they're probably doing evidence-based programs too. It's just that they're not doing evidence-based programs connected to this specific initiative that adds in the technical assistance and support of this intermediary organization. So again, the challenge, if the challenge is indeed to reduce the incidence and prevalence, we not only need that dissemination, but we need to think strategically about where specific interventions are needed. So some recommendations based on this 20 years of doing this, and many of these lessons were learned in hindsight, I have to admit. I mean, we were stumbling our way through this. First of all, better and more sophisticated data systems infrastructure. Both data systems for problem identification, I'm going to talk about that a little bit, and data systems for impact assessment and continuous quality improvement. There's just nobody really funding the data infrastructure that would help communities figure out what they need, what their problems are in a very detailed and targeted and sophisticated way, and also to allow communities across a diverse menu of different interventions to continuously monitor their progress, monitor their implementation quality, and do it in a way that it's not focused on accountability and compliance, but do it in a way that feeds into a system of continuous quality improvement and builds an internal desire, an organizational desire for excellence rather than compliance. A greater focus on capacity building. I mean, this keeps coming up in discussions about scale in different venues, but there really is a significant need to focus on capacity building. Provider organizations that deliver preventive interventions. I'll tell you right now, in 20 years, I've never encountered a provider organization that is only delivering evidence-based interventions or that is only delivering one intervention. So any provider organization that is going to deliver any of the programs on the list that I just showed you is also delivering lots of other programs. And if those programs aren't evidence-based and they don't carry with them all of the strings that go along with monitoring implementation quality, then what we've done is we've actually made the things that work the best the least attractive to the providers. I think we also need to focus on establishing establishing a distinct intervention optimization and delivery infrastructure that's separate from the infrastructure that currently exists through NIH, for instance, to fund the development and discovery and innovation, the development of new interventions and programs. The reality is that the interventions that are evidence-based, that have demonstrated effectiveness in rigorous trials, are not there. I think universally they're not optimized. I mean, part of the reason that the developers this morning talked about how these programs are continually evolving is because there is such a great need for programs that work, for interventions that work, that as soon as a program demonstrates some effectiveness, there is a desire among policymakers and in some cases practitioners and providers to get that program out into the field before it has been optimized. So it's not the most efficient, it's not the least amount of intervention necessary to achieve the goals. and infrastructure for continuous quality improvement at every level. So at the individual community and provider level, but also at state levels where, again, you know, if you think about the amount of money that flows into communities, and think about how much of that money is coming through like federal demonstration projects versus how much is coming from formula and block grants. This is really, I think, where there's an important lever to move, to speed up the progress of going to scale and address a lot of the issues that we've been talking about, is tweaking the formula and block grant processes to reflect all of the challenges that we've been discussing. So again, this is the menu that we've been working to scale up in Pennsylvania. It's very diverse. It's a lot of different programs focused on a lot of different problems for a lot of different populations. It's different developmental periods, and that's really important because if you ask me what it takes to scale up an effective family-focused intervention, I will tell you it depends. It depends what program you're talking about because they're very different. Each of these programs on this menu has a very different level of capacity from the developer and from the National Training and Dissemination Organization, if one even exists. So we have to really think about each of these interventions very specifically and ask ourselves in a very practical way, what will it take to scale up that particular intervention? So we have a model that is, you know, has some similarities across different programs, but is tailored to the needs and the capacity of that particular intervention. And the issue is, you know, it's, you know, I don't want to beat this into the ground, but it's really important to recognize that, you know, if I walk into a pharmacy, everything on the shelves is evidence-based. But that doesn't mean I should walk into the pharmacy and just grab something, knowing that it's evidence-based, and take it home and take it. I first need to know, you know, I need some diagnosis. I need to know what my underlying issues are. Even thinking about the difference between two different cough medicines. You know, do I have is it chest issues? Is it sinus issues? Communities likewise need that level of diagnosis. I mean, this is really part of what communities fundamentally struggle with in trying to wade through all of the readily available, for instance, online registries of evidence-based programs. It's just that that's not enough. It's important, but it's not sufficient. So in Pennsylvania, the way we have been addressing that is before we scaled up these evidence-based interventions, we first scaled up this community data-driven strategic prevention planning framework called Communities That Care, that organizes communities, guides them in collecting local epidemiological data that helps them identify and prioritize specific risk and protective factors that they want to target, and then go and seek interventions that might address their narrowly defined set of priorities. And I'll refer you to this great document by the Society for Prevention Research that really has been promoting this idea of a national need for community-level infrastructure for surveillance, for epidemiological surveillance on an ongoing basis. There was mention this morning of the importance of backbone organizations, and I'm sure you've seen this article from the Stanford Innovation Review. And so you can think about Communities That Care as the backbone organization at the community level, but also think about this state-level intermediary organization that I'm going to talk about as the backbone organization at the state level, and both of those are important. So Pennsylvania began actively disseminating that list of blueprint programs in 1998, and by 2001 they were already seeing that communities that were given grants to try to replicate one of those programs were really struggling with the implementation, with the training, and so forth. And so they attached an additional technical assistance component to that to make sure that their investment in these communities was going to pay dividends and good outcomes. That evolved from 2001 to about 2007. That continued to evolve, and those policymakers continued to gain a greater understanding of the importance of high-quality implementation, fidelity, and sustainability, and really a practical recognition that it wasn't as easy as just giving people a list of what works and giving them money and saying, take the money and do something that works. So they developed, beginning in 2008, Pennsylvania, it first started with funding from the Pennsylvania Commission on Crime and Delinquency. They funded this state-level intermediary organization that had three specific goals. One was support to these community prevention coalitions who were doing this data-driven needs assessment and providing this backbone support organization and prevention infrastructure at the community level. Support and technical assistance to the individual specific evidence-based interventions that they were providing grant funding to these communities to implement. And then a third component that was about improving the quality of the juvenile justice system itself. So not necessarily the interventions, but the practices of the juvenile probation departments and juvenile courts, for instance, to make sure that they were grounded in the latest research about child development and trauma-informed care, for instance. This resource center has become what is called the EPICenter, the Evidence-Based Prevention and Intervention Support Center. So this is a state-level intermediary organization that pursues those three distinct missions that I just talked about. And you know, so we're familiar with. I want to talk about the need for a state-level intermediary organization like that. So we're familiar with this sort of fantasy model of how these interventions are supposed to go from bench to bedside, and it implies that there is this intervention redesign component that where the interventions, after they've demonstrated some initial evidence of efficacy, would be optimized and redesigned, hopefully with the input of communities and end users. But that's communities see it more like this. Communities see evidence-based interventions as sort of Rube Goldberg machines that are just unnecessarily complicated. And when they come and ask us legitimately, you know, well, what is all this really necessary? Do I have to do all 18 lessons? And you know, as we've heard, we can't empirically answer that question. Again, that creates an imbalance between the things we're trying to get communities to do and the things that they've naturally been attracted to. So we heard the panel this morning was fantastic for me to witness. It was so great to hear the developers of these different interventions talk about all the challenges that they're aware of. So imagine, Carolyn, for instance, that list of challenges that she talked about. Imagine having to deal with all those challenges in every single community and every single state that wants to adopt her program. That is a Herculean task, and it speaks to this observation that we cannot continue to put all of this responsibility and burden for scale-up at the feet of the developers. It's just not realistic. So what we try to do in Pennsylvania as this intermediary organization is really to address some of those challenges very specifically. So here we're talking about, in the incredible years, I just used this as an example. We're doing the logistics of scheduling the trainings, working as an intermediary with the program developer. We're making sure that communities are ready before they adopt the program, making sure they understand ahead of time what it's going to take to evaluate the implementation of the program and the effectiveness of the program. We've developed state-specific evaluation tools that meet the needs of the state funders who are funding the programs. And we've convinced the state to add a quality assurance requirement into the grants that they fund. So when the state funds a community to adopt any of these programs, by the end of the second year, that community has to provide implementation data to the developer to convince the developer that that community is implementing that program with sufficient quality and fidelity. And here's, some tips for submitting the videos. So this prevention support infrastructure it's guided by Abe Wandersman's interactive systems framework, which talks about the prevention delivery system, the prevention support system, and the prevention synthesis and translation system. And we're specifically, in addition to the, well, let me just skip ahead a second. In addition to building program-specific capacity that focuses on these interventions, we're also building general prevention capacity. We're trying to develop the capacity of these provider organizations to try to counteract that imbalance between, you know, if we focus on only developing their capacity to do a specific intervention, and they don't, they're doing lots of other programs and interventions, then we've created this imbalance. So we're trying to build the capacity of the organization as a whole to be data-driven, to understand the importance of research, to understand the importance of quality and fidelity and sustainability planning. But we're also taking on the role of being the conduit between the program providers and the funder, and between the funder and the program developer. I can tell you, at any given time in Pennsylvania, there is at least one program on that menu that I showed you that is at risk of just being dumped, either because the providers have just lost patients because they can't work through all the challenges, or the state funding agency has lost patients and they just can't work through all the challenges. And it is because, we don't all have the same mission. We like to think that, we're all in the business of better outcomes for families, but we have to recognize the realities that we're driven by other things. Practitioners have their needs, policymakers have their needs, researchers have their needs. So it really is the role of the intermediary organization to be the one that accepts the responsibility for solving whatever problem occurs that's going to interfere with the effective scale-up of these interventions. And I'll stop there.